The liver can be inflamed without a virus, and when that happens, the cause is usually one of 5 things: an immune system attacking the liver, alcohol, a drug, a blood pressure that dropped, or metabolic disease. Each one has a signature you can read off the history and a handful of laboratory values. Today, we take them one at a time, and by the end, you should be able to look at a patient with a raised aminotransferase and negative viral serologies, and know exactly where to go next. 3 numbers to frame this. 1 in 4 American adults has metabolic dysfunction-associated steatotic liver disease. That makes it by far the most common liver disease you will see. 70% of autoimmune hepatitis occurs in women, and only about 5% of a dose of acetaminophen goes down the toxic pathway. But that 5% is the entire story of acetaminophen poisoning. Common does not mean unimportant, and rare does not mean you can miss it. Here is the plan. First, autoimmune hepatitis. It's antibodies. Who needs treating, and what we treat with. Then alcohol-associated hepatitis and the scores that decide steroids. Then acetaminophen, where the toxicity comes from and how to stop it. Then 2 shorter ones, ischemic hepatitis and metabolic steatotic liver disease. 10 objectives, all of them practical. We start with autoimmune hepatitis. This is the liver being attacked by the patient's own immune system. It is uncommon, but it is one of the few causes of chronic hepatitis that responds dramatically to treatment, which means missing it costs the patient a liver. It also has a habit of presenting in 2 very different ways, silently, or as fulminant liver failure. Autoimmune hepatitis is 70% female, and it is bimodal. It presents in the 2nd decade of life, and again in the 5th. 40% arrive with severe disease, 3% with frank acute liver failure. Those patients have an aminotransferase above 10 times the upper limit of normal. But here is the other face of it. 34 to 45% are completely asymptomatic, found on a routine panel. Same disease, utterly different presentation. 4 categories. Type 1 carries anti-smooth muscle antibody and anti-nuclear antibody, and in 10 to 30%, anti-soluble liver antigen. That last one matters because it marks more severe and more relapsing disease. Immunoglobulin G is often raised. Type 2 carries anti-liver kidney microsome 1 and anti-liver cytosol type 1. Overlap syndrome is autoimmune hepatitis plus primary biliary cholangitis. Suspect it if the anti-mitochondrial antibody is positive. And drug-induced disease looks identical serologically. These drugs can produce a picture indistinguishable from autoimmune hepatitis. Among antimicrobials, minocycline and nitrofurantoin, both often given for months. Among biologics, infliximab and the immune checkpoint inhibitors, which we now see far more often in oncology patients. And then hydralazine, alpha-methyl-dopa, and the statins. The point is simple. Before you commit a patient to long-term immunosuppression, take a proper medication history. Stopping the drug may be the whole treatment. Autoimmune hepatitis rarely travels alone. Thyroiditis is the commonest companion. Then arthritis and Sjogren's syndrome, ulcerative colitis and celiac disease on the gastrointestinal side, and a Coombs-positive hemolytic anemia in the blood. 2 practical consequences. If a patient with any of these develops a raised aminotransferase, think of the liver. And if you diagnose autoimmune hepatitis, go looking for the others, particularly the thyroid and celiac disease. There is no one test that makes this diagnosis. You build a case out of 4 pieces. The serologies, a raised immunoglobulin G, negative viral serologies, and the biopsy. The scoring system combines all 4. And the biopsy is where it becomes convincing. Interface hepatitis, inflammation eating into the plate of hepatocytes at the edge of the portal tract, with a lymphoplasmacytic infiltrate. That combination has high specificity and moderate sensitivity, which means when you see it, you can trust it. 5 indications to treat. 1. An aminotransferase above 10 times the upper limit of normal. 2. An immunoglobulin G above twice normal, together with an aminotransferase above 5 times normal. 3. Bridging or multiacinar necrosis on the biopsy. 4. Cirrhosis with active inflammation on the biopsy. 5. An aspartate to alanine aminotransferase ratio above twice normal in a patient who has symptoms. Notice that 2 of the 5 require tissue. This is one of the places where a biopsy genuinely changes management. 3 induction regimens. Prednisone on its own. Prednisone with azathioprine, which is the usual choice because it lets you taper the steroid faster. Or budesonide with azathioprine. And budesonide has one hard rule: only in a patient who is not cirrhotic. Its whole advantage is heavy first-pass metabolism in the liver. And in cirrhosis with portal shunting, that advantage disappears, and you simply get systemic steroid. All 3 regimens achieve remission in 65 to 80%. 2 paths from here. If it works, and it works in 65 to 80%, you taper the steroid as the patient tolerates it. But be honest about what follows. Relapse happens in 50 to 80%, which is why maintenance immunosuppression is usually continued rather than stopped. If it does not work, or the patient cannot tolerate azathioprine, the second-line agents are cyclosporin, tacrolimus, mycophenolate mofetil, and in refractory disease, rituximab or infliximab. Pause here and reason it through. A 19-year-old woman, 2 months of fatigue and joint pain, recently diagnosed with autoimmune thyroiditis. No alcohol, no supplements, no new medications. She is icteric, but has no stigmata of chronic liver disease. Her alanine aminotransferase is 900, aspartate aminotransferase 700. Alkaline phosphatase is barely raised. Bilirubin 4. Every viral serology is negative. What one blood test would you send next? Everything points one way. A woman in her 2nd decade, another autoimmune disease already diagnosed, a marked hepatocellular pattern, and no viral cause. Send the immunoglobulin G level and the autoantibody panel. Then biopsy her. And note why this is urgent. Her aminotransferase is above 10 times the upper limit of normal. That on its own is an indication to start immunosuppression. Untreated. This is the disease that quietly becomes cirrhosis in a 19-year-old. Now alcohol-associated hepatitis. This is not simply a raised aminotransferase in someone who drinks. It is a distinct clinical syndrome with a real short-term mortality. And the whole management question comes down to one decision. Does this patient get glucocorticoids? There are scores that answer that. And there is a list of situations where the answer is, no matter what the score says. The bedside picture is fairly specific. Progressive jaundice, a liver that is enlarged and tendered to palpation. Fever, ascites, and anorexia. The word to hold on to is progressive. This is jaundice that is deepening over weeks in someone who is still drinking. That is different from a patient with stable compensated cirrhosis. And the fever is worth a warning. It can be the disease itself, but you cannot assume that. Infection has to be excluded. 4 laboratory findings read together. The aspartate aminotransferase is usually under 400. If it is in the thousands, this is not alcohol-associated hepatitis, and you should be looking for ischemia or acetaminophen. The ratio of aspartate to alanine aminotransferase is above 2 to 1. The total bilirubin is above 3 and rising. And the international normalized ratio is raised with a leukocytosis. That white count can be high without any infection at all. But it must not be assumed. Why does the aspartate aminotransferase run higher than the alanine aminotransferase? 2 reasons. Alanine aminotransferase depends on pyridoxal 5-phosphate as a cofactor, and chronic alcohol use depletes it. So the alanine aminotransferase simply cannot rise the way it otherwise would. At the same time, alcohol injures mitochondria, and mitochondria contain their own form of aspartate aminotransferase, which spills into the blood. Put those together, and the ratio inverts. That is the classic 2 to 1. The Maddrey discriminant function is the oldest of these scores, and still the most used. It is 4.6 times the difference between the patient's prothrombin time and the control prothrombin time, plus the total bilirubin. A score of 32 or above defines severe disease. And at that threshold, untreated 1-month mortality is 30 to 50%. That is the number that justifies giving steroids to a patient who is also at risk from them. 2 more scores. The Lille model is calculated after 4 days of treatment, or after the first week. A score above 0.45 predicts a poor response to continuing glucocorticoids, and is associated with worse 6-month survival. Think of Lille as the stop rule. Maddrey and the model for end-stage liver disease tell you whether to start. Lille tells you whether to keep going. And the combination of Lille and MELD together is the best predictor of mortality we have. Consider glucocorticoids if any one of 3 things is true. A Maddrey discriminant function of 32 or above, a model for end-stage liver disease score above 18, or the presence of hepatic encephalopathy. And be clear about what the treatment achieves. Glucocorticoids reduce 1-month mortality. They do not reduce 3-month mortality. That is an important thing to say honestly to a family. The steroid buys time and survival through the acute illness. It does not change the trajectory of the liver disease. The regimen is either methylprednisolone, 32 milligrams a day, or prednisolone 40 milligrams a day for 4 weeks, followed by a taper over 4 to 6 weeks. And do not treat the nutrition as an afterthought. Get a nutrition consultation early. The targets are 35 to 40 kilocalories per kilogram per day, and 1.5 grams of protein per kilogram per day. These patients are profoundly catabolic, and undernutrition is an independent predictor of how they do. And here is the list that overrides the score. Do not give glucocorticoids if they're ICE-active gastrointestinal bleeding, uncontrolled bacterial or fungal infection, uncontrolled tuberculosis, acute kidney injury, or untreated hepatitis B. Every one of these is a situation where immunosuppression makes the immediate threat worse than the hepatitis, which is why the sequence matters. Look for infection first. Treat it, then reassess whether the patient is a steroid candidate. Not the other way around. There is one more option: early liver transplantation in carefully selected patients. This used to be impossible because of fixed abstinence requirements before listing. Outcomes in rigorously selected patients have been good enough to change that in many centers. Selection is strict and varies by program. The practical point for you is about timing. If a patient with severe alcohol-associated hepatitis is not responding, that is the moment to involve hepatology, not after another 2 weeks of watching. Now, acetaminophen. This is the single most common cause of acute liver failure in the United States, and it is also the one where a specific antidote genuinely works. If you give it in time, everything about managing it follows from one piece of biochemistry, so we start there. Follow the drug. Over 90% of a dose of acetaminophen is conjugated into non-toxic metabolites and excreted. About 5% goes down a different route, through the enzyme cytochrome P452E1, and that route produces NAPQI, a directly hepatotoxic metabolite. Normally, glutathione conjugates the NAPQI and renders it harmless. In overdose, above roughly 10 grams, the glutathione stores are depleted, and the NAPQI is left free to injure the hepatocyte. There are 2 ways to get here, and only one of them is an overdose. The first is straightforward. More than 10 grams overwhelms glutathione directly, usually a single intentional ingestion. The second is the one that catches people out. Cytochrome P452E1 is induced by fasting, by alcohol, and by certain anticonvulsants and anti-tuberculous drugs. In that patient, injury occurs at 2 to 6 grams, a dose that is on the packet. That is the malnourished drinker with a toothache. The time course is what makes acetaminophen dangerous. The first symptoms are nausea, vomiting, and abdominal pain, nonspecific, and liver dysfunction may not be apparent for 2 to 6 days. So a normal set of liver tests in the emergency department reassures nobody. By the time the aminotransferases climb, the window in which the antidote works best has already narrowed, which gives you the rule: treat on the history and the drug level, not on how well the patient looks in front of you. 3 steps in order: decontaminate, nasogastric lavage, and activated charcoal if the patient presents within 4 hours. Give N-acetylcysteine. It replenishes glutathione, and it is effective up to 72 hours after ingestion. And consider early transfer to a transplant center. The mistake is waiting for encephalopathy before making that call. By then, transfer is far more dangerous, and the patient may already be beyond the window for listing. The dosing. Oral is the preferred route. 140 milligrams per kilogram as a loading dose. Then 70 milligrams per kilogram every 4 hours for 17 further doses. And here is the judgment call. Have a low threshold to start it even when the acetaminophen level is low or undetectable, particularly when the time of ingestion is unknown, or when the ingestion has been chronic above 4 grams a day. When in doubt, start it. N-acetylcysteine is safe. The alternative is not. Work this one out. A 48-year-old man who drinks daily and has been eating poorly. 4 days of dental pain, taking about 3 grams of acetaminophen a day. There was no single overdose and no intent to harm himself. He is nauseated with right upper quadrant tenderness. His alanine aminotransferase is 2,100. His aspartate aminotransferase is 3,000. His international normalized ratio is 1.8, and his acetaminophen level comes back undetectable. Does he get the antidote? Yes, he gets it. The level is low precisely because this was chronic ingestion rather than a single overdose. The parent drug has already been metabolized, and the injury is from NAPQI, not from the acetaminophen you are measuring. Meanwhile, alcohol has induced his cytochrome P452E1, and fasting has depleted his glutathione. 3 grams a day is more than enough in that setting. Start N-acetylcysteine now, and follow the international normalized ratio, not the drug level. 2 more to finish. Ischemic hepatitis, which you diagnose from the enzyme pattern and the blood pressure chart, and metabolic dysfunction-associated steatotic liver disease, which is the one you will actually see most days. They sit at opposite ends of the spectrum. One is acute and dramatic. The other is silent for decades. Ischemic hepatitis, often called shock liver, has a pattern you can recognize instantly. Aminotransferases above 1,000, a markedly raised lactate dehydrogenase, and a ratio of alanine aminotransferase to lactate dehydrogenase that is often below 1.5. That ratio is what separates it from viral and toxic injury. The bilirubin rises later and rises high, and the mechanism usually requires 2 hits: raised venous pressure from heart failure, plus reduced arterial flow and hypoxia. Not shock alone. Get these 2 terms right because they are used loosely. Metabolic dysfunction-associated steatotic liver disease is fatty infiltration of the liver, plus the absence of another cause of steatosis. No alcohol, no hepatitis C, and on biopsy it is steatosis without inflammation. Metabolic dysfunction-associated steatohepatitis adds inflammation, with or without fibrosis. That distinction is the whole prognosis. Steatosis alone is largely benign. Steatohepatitis is the form that progresses to cirrhosis. 1/4 of the United States population has metabolic dysfunction-associated steatotic liver disease. In type 2 diabetes and obesity, the prevalence is over 60%. Only 2 to 5% of that has crossed into steatohepatitis, which sounds reassuring until you do the arithmetic on the denominator. And once there is fibrosis on the biopsy, the risk of cirrhosis in steatohepatitis is about 30% at 10 years. That is the group worth finding. 80% of these patients have no symptoms at all. When the enzymes are abnormal, the alanine aminotransferase is typically above the aspartate aminotransferase, which is the opposite of the alcohol pattern. But here's the trap. A completely normal set of liver enzymes does not exclude steatohepatitis on biopsy, so you cannot use the liver panel to rule this out. Case finding is driven by the risk factors. Diabetes, obesity, and the metabolic syndrome are what should make you look. Liver biopsy remains the gold standard and is still the only way to grade inflammation and fibrosis definitively. But it is rarely where you start. The FIB-4 index and the fibrosis score predict advanced fibrosis with a positive predictive value above 80%. And they are at their best used the other way round, to exclude advanced fibrosis and reassure. Elastography, whether vibration-controlled transient or ultrasound-based, is a reasonable alternative and increasingly the practical first test. 4 things change the liver. Weight loss of 10% or more with exercise, which still has the best evidence of anything on this slide. Control of diabetes and lipids, including the glucagon-like peptide-1 receptor agonists. Bariatric surgery in appropriate candidates. And resmetirom, which activates the thyroid hormone receptor beta and is the first liver-directed drug approved for this disease. Lanifibranor and a thyroid receptor beta agonist with a fibroblast growth factor 21 analog remain under study. And here's where it ends if nobody looks. Hepatocellular carcinoma is a recognized complication, usually arising in steatohepatitis that has become cirrhotic, which tells you what to focus on. Identifying fat is easy and mostly uninformative. Identifying fibrosis is what changes anything. Fat is common. Fibrosis determines the outcome. And once cirrhosis is established, this patient enters hepatocellular carcinoma surveillance like any other cirrhotic. 7 ways this goes wrong. Calling an aminotransferase rise alcoholic without the ratio to support it. Giving steroids before excluding infection. Withholding the antidote because the acetaminophen level is low. Missing therapeutic dose acetaminophen injury in the fasting drinker. Forgetting that autoimmune hepatitis can present as acute liver failure. Using budesonide in a cirrhotic, where its first pass advantage is gone. And excluding steatohepatitis because the liver panel came back normal. 6 things to carry with you. 1. Autoimmune hepatitis is a young woman with another autoimmune disease, a raised immunoglobulin G, and interface hepatitis. 2. Any of the 5 criteria means treat. 3. Alcohol-associated hepatitis has an aspartate aminotransferase under 400 and a ratio above 2 to 1. 4. Maddrey 32, MELD above 18, or encephalopathy means consider steroids, unless infection, bleeding, or kidney injury says no. 5. Treat acetaminophen on the story. 6. Hunt fibrosis, not fat. These are the sources behind today's teaching. The American Association for the Study of Liver Diseases practice guidance on autoimmune hepatitis. Their guidance on alcohol-associated liver disease. The Journal of the American Medical Association Review of Alcohol-Associated Liver Disease. Their guidance on fatty liver disease. And the Cochrane and British Medical Journal reviews of paracetamol overdose. Thank you for watching. Verify everything here against your own institutional protocols before applying it at the bedside.